If you're trying to conceive and feeling overwhelmed with fertility advice, then this podcast is for you. Welcome to Don't Tell Me to Relax, your fertility podcast and antidote to unhelpful fertility information. I'm Hannah, a fertility acupuncturist, teacher and campaigner for better fertility education. This podcast aims to empower and inform you about your menstrual cycle and fertility. It's basically all that information you didn't get in sex ed at school, with the aim of improving your understanding of your reproductive health and optimizing your fertility. Hello everyone and welcome to this week's episode. This week I am joined by Emma from the Evewell, and who is also known as Emma the embryologist. Is that right? Emma the embryologist on Instagram?
Yeah.
Thank you so much for joining us, Emma, and for giving us your time. You're literally sitting there in labs. Do you call them scrubs or uniform?
Yeah, we call them scrubs or very, very comfortable day pajamas, but yeah, scrubs.
So you are literally in clinic as we speak. And so thank you for coming and joining us. It would be great if you could do a little introduction. Tell us who you are, where you work, what you do.
Okay, so as you've said, I'm Emma. I've been an embryologist. This is my 21st year of embryology, which actually blows my mind a little bit that it's been that long. I started my career straight out the back of university and I got given a job, very grateful to the NHS. I was trained in the NHS for 6 years. I then moved over to the Lister Fertility Clinic, where I spent 13 years and got exposure to probably everything under the sun, because it's such a huge clinic that you see so many different things. And it's during that time that I realised my personal passion is in embryo development and genetics and genetic disease, why embryos grow, why they don't grow. And genetics became a really, really big part of my embryologists at some point do tend to specialize. So that was my bag, so to speak. And hence I then got asked to come and join the Evewell as the lab manager, where we are very, very heavy on doing quite interesting genetics work. And I have been here for 2 years and I am now the head of the embryology team over here. We've got 2 clinics, one in Harley Street and one in Hammersmith in West London.
Amazing. And so for anybody who might be at the beginning of their IVF journey, they might be thinking about IVF in the future. Can you explain to us the role of the embryology department and how it is different from the consultancy bit of IVF?
Yeah, so the consultancy bit of IVF is probably the bit that you do the most facing on with your doctor. It's trying to work out who you are, what your needs are, what your hormones are, what your uterus looks like, what your ovaries look like, all the stimulation, all the drugs. But at the point where you need to actually create, if you are doing IVF or ICSI treatment, or you're actually having, we call them gametes, so your eggs and your sperm taken from you and put into a laboratory situation where they will be put together or prepared or looked after, depending on what treatment you're doing. It isn't a doctor that does that. It is a scientist. It is a scientist that has been trained to handle embryos and understands what needs to be done to keep those embryos alive, to create those embryos, to grow those embryos. We are the experts in understanding what embryo development should look like, what it doesn't look like, what all that means. And then we work as a team as part of a discipline of an IVF unit, where once the doctor has done their bit, ultimately, for those, if you are doing IVF treatment for about 5 or 6 days, you are in the hands of the embryologist, because in my lab especially, I've got a lock on my lab door and it's a no entry policy. It's a very much, it's a very calm environment. It needs to be very clean. Nobody comes in, and any information that comes out of that laboratory comes through us. We are the experts at the eggs, the sperm, the embryos, the freezing, the thawing. It all has to be handled by specifically trained individuals, and that's what we are.
I mean, what an amazing job that I presume it hasn't been around for how many years has embryologists been around in the sort of this form?
Oh, this gives me a really good opportunity to highlight the first embryologist in the world was actually called Jean Purdy, and she gets forgotten about so many times. She was the nurse that was involved in the creation of Louise Brown. Right. Everyone talks about Steptoe and Edwards and all the rest of it, but actually it was Jean that did the the culturing, the actual real nitty gritty handling of that embryo that led to Louise Brown. So embryology came from nursing, and then it became much more of a scientific thing. We realized that you desperately needed it was so scientific that you needed really speciality hands in it. So yeah, probably early 80s, and then more so 90s, noughties, it became a really, really tightly controlled profession as well. We've got our own regulations, our own governing body. We've now got our own training program. But yeah, so we're quite a new breed, I suppose. There's not a huge amount of us across the UK. And actually what's really interesting is we generally all know each other because we've either worked together or we go to a lot of conferences together. So it's also a really friendly community. You do share information. We're actually all in it for the same reason. There isn't a competition here. We're all trying to get our patients pregnant. So we talk to each other quite a lot as well, quite openly.
And so we were just talking before we came on about this idea of, before you go into IVF, about sort of preparing, because I guess you know, from when you deal with eggs and sperm, you want that egg and sperm to be the best quality it possibly can be. And we talk about this a lot. It's on Instagram. It's what people ask a lot around. Can I improve egg quality? What can I do for sperm quality? So can you talk a little bit about that from your perspective? Like, what does that actually mean? And how would you advise somebody to actually prepare before they get to the point of you having their eggs and sperm?
Yeah, so I think it's really important to say when we talk about gametes, like I said, I use the word gametes a lot, and I will use them a lot because it's the term. So please excuse the fact that I do use science speak quite a lot. But a gamete is an egg or a sperm. A man produces sperm, a biological female produces an egg. That is just the laws of science. Now, I think what's really interesting is that eggs and sperm both take 120 days on average to be produced or recruited. I think women are born with all their eggs in their ovaries, but there is a process of what we call recruitment, where the egg is getting ready to be released, whether that be in ovulation or in IVF stimulation. And that process still takes 120 days. Same with a man. A man's sperm is ticking over all the time and the testicles being created, but it takes 120 days from the first part of cell to making this sperm that is ejaculated or used in treatment. So there are things you absolutely can do to make sure that whatever you utilize in, whether that's natural conception or whether that's in an IVF cycle, that you are in the best health place that you can be when the eggs and sperm we're using or you're using come to be ejaculated, ovulated, put in a dish, all of those things. Because nutrition and lifestyle, we know, play a huge part in the functional development of all of our organs. So why should your ovaries and testicles be any different? They're not. We can do something about that. We can take control. There's amazing nutritionists out there. There's obviously your support. There's people that have got degrees in this that can help understand what we need for egg and sperm health. But then I think it still needs to be said that there are some things that we can't do anything about. We can't change our age. We can't change our biological clock. And we can't change a man that maybe has had a testicular trauma or has had something really functional happen, cancer, chemotherapy, that has had an adverse effect on our gametes. But what we can do is, with whatever gametes we have got, we can make them the best that we can get.
And do you have any kind of, what are your sort of top 3 things that you would say to everybody, like to stop doing or to start doing before they went into this process in terms of lifestyle and health?
Oh, yeah. I mean, smoking and vaping has to go. I mean, there is recreational drugs, smoking, vaping. It is very, very well documented that the effect of that on male and female fertility is enormous. Vaping now is coming out as being one of the most problematic things we've seen in sperm health. I don't know if the study's been done, and it's too new probably in female health, but it's not good. And we know that things like all recreational drugs are not good for sperm health. A lot of it has been done in sperm because it's easier to look at, I suppose, than it is in egg health. So that has to go. Your lifestyles need to be better. I'm not again, IVF, trying to conceive over and over again, it is, I've lived this journey. It's a grueling part of your life. You live your life in 2-week blocks. It's awful. No one is telling you to take the fun out of your life, but there has to be some restraint. There has to be some reduction in alcohol. There has to be some input of really good nutrition factors into your body. What you put in, you will get out, and that's actually true for many things. So I think my main take home message is, if I see, again, your weight being a healthy weight, looking after your exercise, making sure you're doing all the things that makes your body function better. It's not false. It's not made up. It actually does. So I think for me, if someone sits in front of me and says that, that the lifestyle is what it is, then that definitely needs to be adjusted. And I think you should talk to the professionals about that. I'm not a nutritionist. I do not know exactly the bits and bobs, but I think there are some fairly obvious things that we can all be doing to make a good start.
Absolutely. And I really like, you do a lot of posts, educational posts on Instagram, and you do a really good series that really caught my eye around this idea of what you can control during this process, what the person who is going through it can control, what the clinic can control, and what is out of your control, which I think is a really great way of dividing it all up, because in many ways there is so much of this process that you can't control, that is, we can't explain, we don't understand a lot about it. But I guess the lifestyle, the preparation, the nutrition stuff is something that people can definitely take control of and do themselves. Can you talk a little bit about that from like the clinic's perspective of what the clinic or the embryology unit can control?
Yeah, so obviously we can't control the eggs and the sperm that we receive into the laboratory. We can control what we do with. So if we go back a step, so I suppose the control series started for me because of the level of guilt I was seeing in patients and the amount of blame they had on themselves for things not working. And what I was trying to highlight is that this journey is hard enough. And actually a lot of this is outside everyone's control. But to make it in our control as much as we can, we all need to do the very best that we can to make sure that the bits in our control are the bits that we do the best that we possibly can. So for patients, I actually think the only thing in their control is what they do before an IVF cycle, what they put in their body, how they prepare themselves, what advice they get, how they advocate for themselves, which is a lot of why these posts came along. I'm a massive believer in, if you educate properly, people know the right questions to ask and they can advocate for themselves. All of that is something that as patients, or people trying to conceive, you can control. You can make changes to control that. You can take your drugs on time. You can turn up to your appointments on time. You can have your scans on time. You can be involved in your treatment. But to that point, in all honesty, that is where it ends, because once your gametes come out of your body, there are elements of it that I can control. So from an embryology perspective and running 2 labs, I feel my control comes from making sure my staff are well trained, making sure that I am monitoring all the results all the time, making sure my staff are educated. I also, with the Evewell, we actually do consultations for all of our patients beforehand, before they even come anywhere near the laboratory, and the stressfulness of that week, to make sure that they know when we will call them, when they should expect what we're going to do, so that, again, it doesn't feel like they're at this loose end of no control. We will control that part. We will be able to give you the advice and the information and the embryos and all of that. But for me, it's about making sure that any process we do in the lab is completely validated. Is this working properly? We talk a lot about KPIs, so our key performance indicators, so our fertilization rates and our survival rates and all of that. All of that is so tightly in my control to monitor. What I can't do is change what happens to that egg and sperm once we've done the very best that we can. So even the bit between what we call day 0 at egg collection and day 5 at embryo transfer or blastocysts, which we might, I'm sure we'll talk about, that growth pattern, once I've done my bit and I've made them fertilize, that's out of my control. I can watch it. I can make decisions about it. I can use my knowledge to understand it, but I can't change it. So I think it's also, from a patient perspective, understanding that the bit that we do well is the creation of the embryos. And then when we come to freeze them, that's all very tightly controlled. But there is a lot of it that, unfortunately for me, is outside of my control. And a lot of that has to do with the age of the egg, or the embryo itself, or the cause of infertility, or the overriding quality of the gamete because the preparation wasn't there, or be that because actually someone's had chemotherapy and their sperm count's really low. And there's outside what we call environmental factors that nobody knows about that we can't control. So I think it's understanding that bit is actually out of everyone's control, because you can't change the biological clock, and I can't change the age that the eggs came out of you. But what I can do is try and make as many embryos as possible, so we've got a pool to choose from.
So you just actually mentioned the age of a person as, something that's out of your control. Can you say a little bit about age and how that impacts egg quality and sort of, I know you can't really pinpoint exact ages, but what do you see?
So age is something that defines the quality of our eggs on a genetic level. We're born with all our eggs. So our eggs are held in like a stasis from the minute we're born to the minute we go into puberty. And then we start releasing those eggs. I think it's a misconception as well that you release one a month. You don't. You actually recruit quite a lot every month, and one becomes dominant and is ovulated. And that's what you are left to try and conceive with whenever you are trying to conceive. The younger you come to that conception, the more likely the genetics in that egg are going to be what we call compatible with ongoing human life, or a viable egg. As we get older, the eggs have been sat in our bodies for so much longer, so the genetic competence is decreased. That happens quite dramatically after the age of 40. It definitely happens quite significantly after the age of 37, and there's a gradual slow at the age of 35. So it's not this cliff that everyone talks about, but it is definitely a consideration. So I think when I talk to women that are actively trying to conceive at the age of 40, I try and put it in the context that if we go back to our basics of what we know, 85% of people will have a positive test in the first year of trying naturally. I think it goes to 90% after 18 months. And I think it peaks out at 95% at 2 years, because you're always going to have 5% that don't ever manage to conceive. And I think that's true for women under 38. If you look at that in the older age group, those percentages are definitely reduced. So I think I ask a woman in the age of 40, you could spend the next 12 months trying to have a natural conception with the 12 eggs that you will release. Now, from 12 eggs, I can tell you that only 3 or 4 of them will be genetically normal, because that's the statistics we're working with at this age group. So you can do that, and you may get very lucky and have a baby, but you will have a baby that will then take you 9 months to be pregnant with. And then you will suddenly be 41, 42 before you'll be able to try for a sibling. So that's something to really think about. And I always ask people to try and remember what their family plan looked like when they came to this. So what we could do at 40 is, if you've been trying for a while, is we could do an egg collection. We could collect 12 eggs, and we could start freezing embryos down so that you have got the opportunity to get pregnant later with a sibling, and also have reproductive choice now. Because if you do create a group of 12 eggs, and for whatever reason they don't develop, or they're not viable, or they're not genetically normal, instead of waiting 12 months to find that out, we can move on quite quickly. So with IVF, you're almost shrinking time. You're putting your 12 eggs that you're going to take to conceive in a year down into this one cycle of IVF that will give you hopefully reproductive choice, reproductive understanding, and options to have a family. Because most people don't sit before me and say, and they do, because by the time you've been trying for years, all you want to do is have a baby. But there is an element of me, and it takes a brave person to do it, because I have been looked at very strangely, and people get very upset. But there's an element of me that just says, hold on a minute, let's just pause, and let's just work out what this looks like realistically. If we get you pregnant now, I can potentially get you pregnant now, but I don't want you to sit in front of me at 42 where 1 out of those 12 eggs will be normal, and be absolutely devastated that you can't give your child a sibling. So for me, I would rather people had the education to know that we are declining in fertility once we go past 37, 38, and it does speed up. 39, 40, 41, it is 5% a year that it just drops. Let's take the control. And that is the bit that you can take the control back on. You can decide to have some tests. You can decide to sit in front of someone that knows what they're talking about. You can decide to ask the right questions about what you should be advocating for. And then you can make some decisions about what you do next. If that's not your bag and you don't want to go down the road of treatment, or you, for whatever reason, you can then choose to carry on trying, but at least you know what your chances are. So I advocate for people to get themselves in front of a doctor very, very quickly. I've got friends at 35 that have been trying for 6 months. Get the blood test, get yourself scanned. It astounds me how many women get to the age of 40 and have never had a scan on their reproductive organs.
And in terms of like a cutoff, do you have a cutoff at the clinic?
So we do,
in terms of age?
Yeah, so we won't not treat anyone. I think that's a really important take-home message. There are many clinics that I know have cutoffs to do with blood levels or AMH levels or hormone levels, which I could bang on about all day, but I won't. We will treat people up to the age of 45 with their own eggs, but the realisticness of what that looks like for you will be heavily discussed before you decide to go down that path. I have got women that have had babies with their own eggs at 44, but they are a handful. And I think that you need to be responsible when you are treating patients to give them in the actual statistics of what your potential looks like given your particular circumstances. Because in a woman that's 44, about 1 in 10, 1 in 20 eggs will be potentially genetically viable. We're looking at 5 or 6, maybe 7% of an egg being an egg. And you've still got to get that egg to fertilize and grow and create an embryo. And if a woman is only ever going to produce, because what we do know is that you create less eggs as we get older, because you are heading towards that menopause shift where your body starts to shut down and your ovaries start to go to sleep because they become empty. So I think it's really important to be able to tell a woman, you're a good candidate for this because we could potentially get X amount of eggs from you. But if you've got a 44-year-old woman sat in front of you, which is only going to get 1 or 2 eggs, I think you've got to have some really difficult conversations about where their route to parenthood lies. And it's not always in IVF.
You recently did a post about the idea of ICSI, IVF and ICSI, which I was really interested in.
IVF was all we could do between 1978 and 1995, I think, in the UK. All we had in our arsenal of treatment was to get a sperm sample from a man, get some eggs from a woman, clean the sperm up because it's in semen. So you have to get the sperm out of the semen with some fancy centrifuging and spinning. And then you mix the sperm and the eggs together. You put them back in the incubator. You put on some Barry White and we hope for the best. And we hope that everything fertilizes as it should. And do you know what? It worked, right? It absolutely worked for a huge proportion of patients, but it didn't work for a huge proportion of patients who were dealing with horrendously poor male factor. They weren't offered any treatment. Their only option was donor sperm or adoption or, some other form of finding another form of sperm. So that was until 95. Then when ICSI came along in 95, our world changed completely. We could treat men that had had chemotherapy and had hardly any sperm. We could treat men that had had testicular trauma. We could treat everyone because ICSI is when you can inject a single sperm into an egg. And it became this last resort port of treatment that everyone was really scared of it. And I came to IVF in 2002. And it was still only being used on these really rare cases where you had no alternative. Let's fast forward 20 odd years and let's look at where we're at now with ICSI. It is now part of the reason that we are so successful in what we do. What I would like to see, and this is a very POFAR, or whatever you want to call it, public opinion, because that post was received really well. It was received better than I thought, because a lot of this is based on my clinic, my views, my experience, which is lengthy. But ultimately, I think you have to understand each clinic will have their own success rates and their own reasons for making these recommendations. But what I stand by is that no patient should be having IVF for a diagnostic reason. You do not pay £8,000 to, if someone is concerned that you may not achieve fertilization with standard IVF, you don't use that cycle, which could be someone's only cycle, to find out if it works. If I've got a young patient that's sat in front of me with 0 conceptions, they've got normal sperm count, they're healthy, they've done everything right, and there's not a single pregnancy there at 35, 36, 37, I'm sat there as an embryologist wondering why. I don't want to take chances on your eggs and sperm. I have made too many failed fertilization calls. So a failed fertilization is when we do the IVF and it doesn't work. And we find out from doing it that there's potentially a communication issue between your sperm and your egg coming together to create an embryo. And that might be the cause of your infertility in the first place. I don't want the diagnosis. I'm not interested in it. I've got enough evidence that I'm concerned. I'm going to use ICSI. I'm going to recommend you use ICSI because I know it to be safe and I know it to be really, really effective. I don't know where this scaremongering comes from. There was a paper in 2012 that talks about birth defects. But up until about 2010, like I've just said, we were using it as a case of last resort on men with really, really poor sperm that potentially had an underlying cause that we did never understand. So I'd like to see that paper done again now that we're using it for far more diverse reasons. And I don't think you'd see the same outcome. I think you would see a much more standard, equal view on IVF babies and ICSI babies.
And it's really interesting what you said, because sometimes we have had people in clinic who said, we've been given the option. And I think, well, hang on a minute, that doesn't make sense to me, because exactly like you said, you know, you and I guess it goes back to that, what you can control, what they can, the clinic can control. You know, I want the clinician to be saying to me, or I would want, this is our recommendation, you know, this is what we think we should do, and these are the reasons why we think that we should do it. That's kind of the approach that I think is the best.
Yeah, I mean, personal experience in my clinic, in my setting, again, this comes back to what we were talking about earlier. What can I control? My embryologists are incredibly highly trained. My KPIs, which is my key performance indicators around ICSI, show me that in my clinic, done the way it's done, it is 100% safe. It works incredibly well. And I feel that I get more embryos from using ICSI in the correct cases. I have to add that, because there is absolutely a place for IVF in patients that are sat before you with genetic disease, for example, and they are able to conceive naturally. Then absolutely, then, you know, you absolutely can. If they've got proven fertility, obviously you're not going to add that added benefit. But I want to see it thought about more before you guess. I don't want people to guess. I want people to, I've heard it so many times. I've had doctors say many years ago, and not here, but say things like, oh, well, now at least you know why you haven't been getting pregnant. Well, that's just cost them £8,000 and they might not be able to do this again. So I'm not sure that the diagnosis was worth that much. And now all right, we know what to do next, but can you afford to do it again?
Can you just say a little bit more? Because that's something that I think people often don't know about, is the key performance indicators of clinics, because it's such a minefield of information out there. But so is there a separate one for the embryology unit and the clinic? Is it kind of like, or is it all mixed in together?
A bit of both. So the HFEA, which is our governing body, basically tell us what we what we need to monitor to make sure we are performing at what's called benchmarks. Obviously, pregnancy rates, implantation rates are published very, very badly on the HFEA website, and it's now like nearly 6 years behind, which is very frustrating as a new clinic. So those results are, everything's mandatory, but a lot of it patients won't see. And again, that frustrates me, because I've got it all on a screen in my, and I'm happy to discuss all of these results with anyone, because when you're choosing a clinic, you should be asking these questions about key performance indicators. So for a laboratory, our key performance indicators, so as a clinic, our key performance indicators are: how many eggs are we collecting from patients in age groups? How many of those eggs are mature, because they have to be mature to be able to be fertilized, showing that the stimulation is being done well. And then you come into the lab, and I have got a multitude that I have to check all the time. So I've got fertilization rates with IVF, fertilization rates with ICSI, embryo development rates, which is what we call our utilization rates. So the embryo is actually getting from A to B to a point where you can actually have them transferred, tested, frozen, whatever that is. Because it's all right us talking about implantation rates, but you can only have an implantation rate if you've got an embryo. And I think what people fail to realize is that when clinics publish their statistics on pregnancy rates, they're not even talking about the patients that never got the opportunity to have a transfer, because actually they were underperforming in the growth bit, or the fertilization bit, or the maturity bit. That is hidden. And I would like to see it not, because it's something that if you're doing well, you should be able to talk about. I also have to look at things like freeze-thaw rate. So egg freezing, survival rates with eggs, embryo free survival rates with embryos. We go down to the nitty gritty of biopsy results. Like if you're doing a biopsy in an embryo, making sure that that embryo is surviving that process. So, and that's mandatory. The HFEA tell us that we must have quality indicators and we have to report them at every single inspection. So every clinic has them.
As somebody who is going into this, I guess it would be, and you want to sort of research your clinic, because we always say to people, research your clinics, don't always go to the one that's nearest to you. I know that is a factor, but there is a difference in clinics. And these are the kind of things that are good to know, like what is the embryology department? How are they working? All of that kind of stuff is really important and not often discussed, I don't think.
No, it's not,
and
it should be. And it's about, again, this comes from educating our patients to advocate for themselves, to ask the information that means the most to them. So what is my chance in what I would like to see the question, instead of patients walking into clinics and saying, what is my chance in your setting of taking home a baby? I'd like the reverse of that asked. What is my chance in your setting of creating viable embryos that will give me the chance of having a baby? And also, how many people in my circumstances never got that opportunity because the embryos didn't develop? All of those things are as important, if not more so, than the pregnancy rate, because that only tells us about the patients that are actually having transfers.
Yeah.
So these are mandatory KPIs. They are reportable. Like I said, we all have to do them. And they should be, I think there has to be some element of trust, and I'm not trying to remove all of that, because, we're all trying to do the best that we can to treat patients. But I do think that patients should be able to ask for certain statistics that help them make informed decisions about which clinic they're going to have their treatment at.
Thank you so much, Emma. It's been so lovely to speak to you. Just before we go, have you got, with all your years of experience and, working in this field for so long, are there any top tips? Can we say top tips, or any sort of 3 things that you wish people knew more, or anything that you kind of think, I just wish that was better done, or anything
I think
like that?
we touched on it earlier, but I wish that people were guided quicker into testing their fertility at a younger age. I wish that people, I'm trying to get into one of the senior schools near where we live, because I actually think we need to start these discussions earlier. I wish people knew that this was a real thing.
Yeah.
And that I think what I really wish is that people knew the options available to them. So my top tip is do the research, but don't Google, don't TikTok. Look at, go to professionals, talk to the people that are actually trying to educate and advocate for yourself about and actually my big take home is don't lose sight of what your family looked like when you started this journey, because it all feels like a bit overwhelming and too much when you start to realize that there's a fertility issue. But there are so many things we can do now to try and make sure that your family plans are protected as much as they can be. I think don't be scared to have that conversation, because that's what we're here for.
And that idea of education really is, it's the number one thing that we hear in clinic. The number one thing that people say, I wish I'd known this sooner. I wish I'd done something sooner, and it's so true, isn't it? That kind of education needs to start so much earlier. So we have sort of check-in points through our 20s about that this is important stuff, and we need to know about it. So thank you so much for your time. I will put all your details on the show notes so people can follow you on Instagram and find where you are in clinic. Thank you ever so much. And if you have any questions about today, then do feel free to contact me. I presume you get DMs, Emma, from Instagram. Get in contact if you have any questions about today, and we really hope that you have found it helpful. So we will be seeing you soon. See you next week. Thanks, everyone. If you've enjoyed listening to this and want to find out more, then come and join my free community in Facebook. We have loads of resources. You can catch up on all our previous webinars and be the first to know about forthcoming events. To sign up, just follow the link in the show notes. And if you'd like to work one-to-one with myself or one of the team, then please see our website, hannahpern.com, where you can book in directly or organise a discovery call to find out how we can support your fertility and your reproductive health.